to the friends and colleagues of the Vascular Society of Egypt for this opportunity to brainstorm together about the appropriateness in the superficial venous procedures. Is it appropriate that if we are in America, we have indications that a thermal tumescent is equivalent to non-thermal non-tumescent, while basically in the same year in Europe, another document is stating that a thermal tumescent is superior to non-thermal non-tumescent. Moreover, bringing all the different apples and oranges together in the NT definition. Let's think about if it is time to stop this fire of the thermal tumescent or not. In terms of safety, as always, first we see that there is no major concern with thermal tumescent versus non-thermal non-tumescent, with non-thermal non-tumescent meaning the glue in this specific case demonstrated significant safety also in long follow-up. In terms of recurrences, we can see that there are data, 5 years of follow-up, showing that a specific type of glue compared to a specific radiofrequency ablation can actually even be competitive. The same thing for another type of glue that is coming from another region of the world. But again, 5 years of follow-up shows competitiveness. But always remember that in this analysis, apart taking into consideration the treatment or not of the tributaries, the use or not of venous active drugs, the use or not of graduated decompression stockings, we have to dissect the data as thinking surgeons. If you take these 2 studies, for example, that I mentioned, you will see that despite they were using the same radiofrequency device, at 5 years follow-up in one study, there was a significantly different results in terms of recurrences in the radiofrequency group. How is that possible? Is this appropriate? Is this appropriate investigation evaluation? On the other side, we have to consider that if in NT we put all together, we are making a little bit of a mistake. This is a study that is showing how at 3 years follow-up, a MOCA procedure, if the caliber is over 7 millimeter caliber, there is real no advantage in using, in terms of recurrency, this kind of procedure. In terms of clinical impact, we have data that are recent that are showing us that we still should keep the radiofrequency device close to us, because as you can see over here, it gives the best results in terms of GSV closure. In terms of mean invasiveness, we see every day in the different social media the results of the new techniques that are coming up like IFO. But we should be cautious, not only because IFO has been around for quite a while and finally we get some data, but also because these data are mixed with the procedures of sclerotherapy that has been done in many of these cases, if you really dissect the literature. And if you dissect the recent literature about IFO, you see that the immediate closure is at 42.9% and 1 week 93%. It is very important to understand what is happening in that week. I think also to understand the potential thrombogenic aspects of this strategy, which I think has, of course, great potentials, but it's very important, of course, we assess properly. Not just at the saphenous trunk level, but also at the tributary level, because considering indeed that we have high intensity focus on ultrasound activity, which means thermal energy, we cannot really treat the most superficial tributaries that still might be the responsible of the majority of the reflexes, for which we still have to do some procedure on them. And when we are analyzing the different saphenous trunks, we must remember that there are different hemodynamics. For example, if you're talking about the anterior accessory saphenous vein, we have a literature suggesting that glue might be the best solution. While we are talking about small saphenous vein, we have data that suggest that radiofrequency could be the best solution. This is very important, the hemodynamics part. We demonstrated with the publication of our group showcasing that the incompetence of the ilofemoral tract can increase by 5 times the risk of a recurrence of the saphenofemoral junction. So it's very important that we appropriately compare similar hemodynamics types. And of course we could talk more and more, for example, about the role of sclerotherapy, that in terms of recurrence rate, of course, is less competitive in terms of anatomical recurrence rate. But if you're talking about clinical success and patients' reported outcome, morbidity and complication, and potentially also cost effectiveness, still might be the best solution. All of this can be found in the documents we published along the year following the VWIN events in 2019 about the similarities and controversies in the different guidelines, in 2023 about the fake news and the evidence-based data in venous and lymphatic disease, and now the next step forward with a great group from Canada directly co-working with us toward the valid project presentation, Venous and Lymphatic International Document, to be presented in Rome this September, where I hope you will all be with us, globalizing the evidence while nationalizing the recommendation, meaning that for appropriateness and sustainability, what your working group from Egypt will consider appropriate and sustainable might be different, of course, from what we will consider appropriate and sustainable in other countries. Of course, as president of the UAP, I also have the pleasure of inviting you to join us at the event of October in Buenos Aires. I remain at your disposal, and I'm very certain to be with you due to concomitant engagement indeed with our clinical governance. Thank you so much, and please feel free to reach out for whatever needed.